Now I will continue with the most severe epilepsy, epileptic developmental and epileptic encephalopathy. From Professor Sinvi's presentation, we already know that the cause, the etiology for this is very complex, and we have a lot of genetic cause. And this were our study, which was sponsored by the NAFO State National Foundation for Science and Technology Development in Vietnam. And now I will present our study. This study also has been published in American Journal of Genetics last year. This is the name of my presentation: genetic analysis using target exome sequencing of Vietnamese children with developmental and epileptic encephalopathy. The content will include introduction, subjects and method, result, discussion, and conclusion. For the introduction, genetics play an important role in developmental of epileptic encephalopathy. However, the mutation diagnostic yield is different. Also, the genotype and phenotype relationship is different between syndrome and syndromes. So the aim for the study is 1. Identifying the clinical, subclinical, and therapeutic features in pediatric patients with developmental epileptic encephalopathy suspected for genetic cause. Second, analyzing genotype and phenotype relationship of the identified disease-coding variants. And thirdly, which were the most important to all clinicians, defining the percentage of patients in whom this approach would change the current management. And subjects and method for the study, all Vietnamese children with developmental epileptic encephalopathy referred to Children's Hospital number 2 from June 2019 to April 2020 with the inclusion criteria one set before 3 years, remarkable EEG findings except for rapid patients in the first year and developmental delay. Exclusion criteria is birth trauma-related, metabolic, structural, or infectious etiology, or previously identified chromosome abnormality by karyotyping or array CGRs. And the phenotype were classified into syndromes based on the criteria for ELA. Developmental stage were evaluated during Vietnam too. And that's what we do. For the exome sequencing analysis, technical techniques, but I can explain for you. At first, we collect the blood, and after that, we extract the DNA in Vietnam. And after that, we send the DNA extract into Macrogen lab in Korea, and we get the phosphate in Vietnam. And after that, I work with the bioinformatician in order to select the candidate variant, and we will evaluate the candidate variant by using the criteria for ACMG 2015. And with the highly pathogenic or pathogenic variants, we will do the trial target, we will do the trial standard in order, and we will use the panel for 295 gen DE in order to detect the, get the variant, and after that we will validating the variant based to the ACMG, and in silico analysis we use this program, and after that we will do the voting variants and evaluate by trial standard with the patient and also the parents, and we have the result. That's what our method. And statistical analysis was storing data in Microsoft Excel and analyze it by using the R statistical package with the p-value under 0.05 were considered statistically significant, and we also the risk ratio. And now that the result, I think is the most important. Clinical characteristic. We have approximately 30 patients with the onset A approximately 1 year old and the seizure onset. Most of them have the first seizure in the first year. For the DE syndrome classification, due to the ELA, we can notice the specific DE syndrome in approximately 55 patients. And for the other, we cannot find a specific syndrome for them. So we can classify unspecific DE syndrome here. And after that, for the specific DE syndrome, we have Otahara for Ravat 10, West 4 patients, Lennox-Gastaut 3, Deuce 3, Landau-Kleffner 2, and stated epilepticus during sleep 3. And this is the disease coding variant. We found approximately 19 coding variants in 20 patients because we have one twins. And the higher diagnostic yield is in the group that they have the first seizure in the first year, with the RR ratio is 2.9. And the diagnostic yield, because I have a lot of mapping here, but it's still that technical problem. And the diagnostic yield, you can see, it is very higher. This is detected variant. It is very higher in the one set before 1 year old, and it is very low in the one set after 1 year old. And now we will talk about the disease coding variants. We find 19 variants with 10 pathogenic variants and 9 lightly pathogenic variants. And we do not detect any CNV on the causative variants were de novo. With the inheritance patterns is the 19 dominant and X-linked, no causative variant with recessive inheritance mode. And each variant were identified as unique patient except for SCN1A in 2 twin sisters. And the reported status, we have here with unreported variants before and with reported with different phenotype. We will discuss about the collaborate between the phenotype and genotype after that. And the variant type in missense were the most popular, and after that the no-set and the infirmed variant. Now we will talk about the disease coding variant and developmental epileptic encephalopathy syndrome. For the non-specific, we have a lot of detected here. And also for the group that one set before 1 year old, including the Wet syndrome, the Otahara syndrome, and the Ravat syndrome, we have many mutations detected comparing with other syndrome which happen with the one set of A happen in the second years or later. And this is the coding variants. We have a lot of sodium channel or cation channel scoring variants, and we list here with the green, with the blue is pathogenic variants, and the orange is lightly pathogenic variant. And the most important role for any clinical here is the treatment. Can we change the treatment after we have the genetic analysis result? This is our number of patients. Unfortunately, we have nearly 60%. We cannot find any causing variants, but for the others, we see that we can change the treatment in approximately 10% for this. And the treatment trend in 6 patients, 3 patients with non-specific syndrome, we should change it after we have the genetic analysis result. 1 Otahara syndrome, 1 Ravat syndrome, and 1 West syndrome. Treatment change result in seizure reduction of at least 15% in all of them followed after 6 months. And also we see that we can change the treatment after we have the result for this. It is really beneficial for a ketogenic diet for SCN1A and MC1A, carbamazepine for SCN8A, clobazam for BCDS19, phenytoin for SCN2A related seizure. For this patient, we cannot classify them into the traditional ELA classification. And the discussion. The detection rate and method. The mutation detection rate of next generation sequencing varies from other study, it 10 to 100%. But in this study, we can just detection yield in approximately 14% because we use target exome sequencing on patient, and after that trial sample, target exome sequencing do not have to discover the new genes. If we want to open the diagnostic yield, we choose use trial exome sequencing, but it reduces the cost of conducting. And also, solo exome sequencing will have the reanalysis of newly described epilepsy gene in the future. The detection rate in our patient really very higher in the group of early onset compared with the later onset group. And Ohtahara and Dravet syndrome account for half of the positive cohort with early onset group. And the tip of gene. We have approximately 15 patients at the beginning and 20 patients with mutation. But there are twins, so we just have 19 variants. And we have 11 tip of the gene. And it calls the tip of the gene here. Sodium voltage chains now play an important role here. And we also have potassium channel, glutamate, gadolinium channels, and for other genes. Yes, so at CN1A, sodium voltage channel plays an important role in the result for the study. And this is the tip of the gene. We have missense variant, ion channel, BCDS19, and other gene. We have missense play an important role here. And after that, the truncating, and after that, the in-frame deletion. And novelty of the identified variants. We have unreported variant with 4 variants, and other variants have been reported by other authors. And same variant in a gene can result in different developmental or DE phenotype. And reason because we have polymorphism on the gene and environmental factor that can affect the gene. And this is the variant. We have 5 unreported variant here and report variant with different phenotype here. And this is the report variant with the same phenotype when we compare to other authors. And last, the treatment change is based on genetic testing. The treatment change, it just happened in 6 patients over 20 patients that we can find the mutation for the reason that some, maybe a lot, anti-seizure medications are not available in Vietnam. For example, developmental like this. And also for the very specific phenotype like the Dravet syndrome, we can diagnose them before we have the genetic result because they have a characteristic symptom. So some treatment for patients with a specific syndrome already have been adapted before we have the genetic result. But in 5 to 6 patients with the treatment change experience a positive impact for seizure control, they can have more than 15% reduction of the seizure. We did not detect any CNV. It was very low compared to other studies that they report the diagnostic yield about 3 to 6%. Reason for this is because the sample size is a little bit small, different in patient selection criteria, or limitation for the analysis methods, because we have exclude all of the patients which have been detected abnormal chromosome by the karyotype or array CGH. And however, we use the ES to redo the CNV, so the ES cannot yet be used to relate the chromosome arrays for detection of CNV. This is the weak of our method. So genetic analysis by chromosome microarray for negative patient is highly recommended. And for the conclusions, this is the first study on the genetics of developmental epileptic encephalopathy on Vietnamese children. Strong involvement of genetic etiology in this kind of patient, especially in patients with seizure onset in the first year of their life. And this study also clarifying some of the recently identified genotype-phenotype relationships in developmental epileptic encephalopathy, and we emphasize that target exome sequencing is an efficient method to diagnosis and target treatment that we can do for target treatment prescriptional medicine for developmental epileptic encephalopathy. And at least thank to all for the audience for your listening.